variability in the quality of care that is provided across cancer centers in India. So when we looked at 75,000 patients who came to Tata Memorial Hospital, what we realized was that only 13% of patients came from the city of Mumbai. 87% of them came from thousands of kilometers away just to access basic cancer care. And the problem with something like that is that many of these patients, because of the expense of living in a city like Mumbai to get cancer care, would drop out of treatment. So almost 40% of patients would not complete their treatment, which was suggested at the Tata Memorial Hospital. So about 14 years back, we decided that we would create a network of cancer centers in India, which would try and work towards uniform standards of care. So somebody who's living in the northeastern corner of India, in Arunachal Pradesh or Sikkim or Meghalaya, would get the same quality of care that they would get at Tata Memorial Hospital. So we started with creating resource stratified guidelines for treatment, which are evidence-based, and this has been adopted by the National Health Authority and linked to reimbursement under the Ayushman Bharat scheme. So automatically it brings in a level of quality to care that is provided across these centers. The other aspects that we worked on was quality assurance, and we look at quality assurance in diagnostic pathology because there is a variation in the quality of diagnostics that are available in molecular pathology, so that the uniform pathology diagnostics are offered across the country. Something else which has dramatically reduced the costs of care is pooled procurement or group negotiation for drugs. Newer cancer drugs are extremely expensive, and smaller centers don't have the ability to negotiate with pharmaceutical companies to get lower costs of their medicines. In addition to that, because they are smaller centers and their volumes are low, companies would not find it worth their while to supply medicines to these remote areas. So what we did was to combine the demand of cancer medicines across different cancer hospitals in India and negotiate with the pharmaceutical industry as a group. And the kind of discount we've been able to get ranges from a minimum of 23% to a maximum of 99%, with an average discount of 85%. So a 100 rupee medicine suddenly becomes available for patients at just 15 rupees. And this dramatically brings down the costs of care. The other area that we've been working on is on using digital technology on electronic health records and the sharing of health records to reduce the need for patients to carry across their medical records from one center to another. And we're looking to see how we can use digital tools to leapfrog some of the advances that have happened in high-income countries. The final point I want to talk about is on research, and we will hear more about this in tomorrow's session. Having a network of over 400 cancer centers, which between them treat more than 860,000 new patients with cancer every year, which is approximately 60% of all of India's cancer burden, not only gives us the ability to have uniform standards of care, but it is an excellent platform for cancer research. And research needs to be contextual to the region that we belong. Some research that is done in high-income countries may not apply to countries like ours because of the high costs and the resources that are required. So we created a platform which is ready for researchers within India to exploit and use cancer research. And I'm very excited to say that tomorrow we will launch the esophageal cancer study group within the National Cancer Grid, which will focus on research on esophageal cancer. And we are hopeful that this will improve the outcomes of esophageal cancer not only in India, but globally.